Assalamu alaikum. Now we come to the second part of the obstetric case taking slideshow. In these coming slides, we'll discuss the clinical physical examination. Clinical physical examination will include general examination, abdominal examination, obstetric maneuvers, including the obstetric grips, vaginal examination in an obstetric case, and lastly, the bedside urine analysis for protein and sugar. We start with general examination. The items that should be searched for and examined in the general examination of an obstetric case is gait. We ask the patient to walk and notice the type of her gait. If she is limping, if she had a weak limb, for example, from poliomyelitis, previous polio, or if she was waddling. These types of abnormal gaits may give a clue for the type of pelvis that may affect the mode of delivery later on. The second item is the constitution. What's meant by constitution? Constitution here is meant whether this constitution is feminine or masculine. That's to say, we are all agreed that the female body have different distribution of fat than that of the male body. If the pelvic girdle is wider than the shoulder girdle, this constitution is feminine constitution. If the reverse is present, the shoulder girdle is wider than the pelvic girdle, this is a masculine constitution. Masculine constitution may be seen in certain types of females, such as females with Cushing syndrome, females with polycystic ovarian disease, and it may indicate an android pelvis that had a wider hind pelvis than and narrow fore pelvis. This type of pelvis, android or anthropoid pelvis, which are common in patient with masculine constitution, may give a problem during the process of labor. Okay. Then we assess the build of the patient. The most commonly used equation for assessment of the body build is the body mass index. Body mass index is obtained by dividing the weight in kilograms over the height square in meters. Okay. The normal female body mass index is between 19 and 24. 19 and 24. Then we measure the vital signs, including the blood pressure, pulse, temperature, and respiratory rate. Then we start general examination of the patient from the head to the heel, seeking for abnormal findings. These are pictures for some parts of examination, including the breast development as graded by Turner, the breast examination, thyroid examination, and so on. These techniques of examination are explained extensively in the gynecological case taking. We shift to the abdominal examination. For the purpose of abdominal examination, we may divide the anterior abdominal wall into areas for better localization of the abnormal findings. We may divide it into four quadrants by two perpendicular lines, the midline and intercostal line meeting at the umbilicus. We have here four quadrants: upper right quadrant, upper left quadrant, lower right quadrant, lower left quadrant, and so on. Or alternatively, we may divide it into nine areas, three on the right side, three on the left side, and three in the middle. These nine areas are divided by two vertical lines and two transverse lines. The two vertical lines are two mid-clavicular lines, and the two transverse lines, the upper one is the subcostal line, and the lower one is the intercostal line. These nine areas, the central areas, midline areas, are the epigastric area, the umbilical area, and the suprapubic or hypogastric area, and the two contralateral and the three contralateral areas, including right hypochondria and left hypochondria, right lumbar and left lumbar, right iliac and left iliac. And so we have here nine areas, three in the midline and three on either line of the anterior abdominal wall of the mother. With abdominal examination, we start by inspection, palpation, percussion, auscultation, inspection for the contour of the abdomen, movement with respiration, the subcostal angle, and the umbilicus and the skin of the umbilicus. Hernial orifices should be tested for without straining and with straining. And with palpation, we have two types of palpations. The first is superficial palpation for superficial tenderness and rigidity or superficial masses, and deep palpation for palpating the liver, the spleen, and the renal angles for palpable kidneys, or deep intra-abdominal mass or parietal mass. Here we should note that we can simply differentiate between any mass found if it is intra-abdominal or parietal by asking the patient to raise her head unassisted by her arms. If the mass becomes more prominent, it is a parietal mass. Let's say it is in the anterior abdominal wall. If the mass becomes less prominent, hidden by the by the contracted anterior abdominal wall, it is intra-abdominal mass. This test may be called or termed getting up test. We come to the third examination, which is percussion. Percussion in obstetric case may be may give we have dullness over the uterus, the pregnant uterus. We may have shifting dullness if there is associating ascites or associating ovarian cyst. Shifting dullness in ovarian cyst is absent. Shifting dullness with ascites is present. Auscultation, we auscultate first the fetal heart rate, may hear or auscultate for the placental souffle, and we may hear the intestinal sound in postoperative conditions. These are examples for abdominal examination. Abdominal examination of the spleen, abdominal examination of the renal angles, and the auscultation of the fetal heart sound using the binaural stethoscope, the old method binaural stethoscope, and or may we use the Doppler machine for auscultation of the fetal heart rate. we shift to the obstetric maneuvers. We have mainly 6 obstetric maneuvers, 5 grips, and the fundal level. We start with the fundal level. Fundal level is not a grip, but is a obstetric maneuver. The fundal level, again, each of these maneuvers has its aim, has its aim. Fundal level, its aim is to determine the uterine size in gestational weeks. The fundal grip is to identify which fetal part occupy the fundus uteri. And the umbilical grip, its aim is to identify the fetal back position in relation to the anterior abdominal wall of the mother. That is to say, the determination of fetal position. The first pelvic grip is aiming to determine which fetal part occupies the uterine segment and whether the head is engaged or not. The second pelvic grip aims to determine whether the fetal head is flexed, extended, or midway between extension and flexion. So the second pelvic grip is only done when the presentation is cephalic. It cannot be done in non-cephalic presentations. A combined grip is usually used by experienced specialists, which aims to shorten the time of examination, and by one maneuver he can determine the lie, the presentation of the fetus, and to some extent the attitude of the fetus. We start with fundal level. We shift to the umbilical. For the fundal grip. The fundal grip is performed by your two hands. Your hands. We have here to know the level of the fundus before doing the fundal grip. So each of the obstetric maneuvers depend on the preceding one. So we need to perform the fundal level before we perform fundal grip to identify the level of the fundus for palpation. We start as shown in the figure. Start catching the fundus uteri, gently palpating the fetal part occupying the fundus uteri. We may have just to describe this fetal part. Is this fetal part small or bulky? Smooth or regular? Smooth or irregular? Hard in consistency or soft? Tender to the mother on palpation or not? Palatable, let's say, can be moved independently of the uh, of the rest of the fetal body. Okay. If it is small, it is a head. If it is breech, it is bulk. If it is smooth, it is a head. If it is irregular, it is buttocks. If it is hard, it is the head. If it is soft, it is the buttocks. If it is tender, it is the head. If it is not tender, it is usually the buttocks. If it is palatable, it is the head. Okay. So we characterize the fetal part occupying the fundus uteri by performing the fundal grip. So we can obtain some knowledge from this fundal grip. First, the fetal part occupying the fundus is consistent with the head, for example. So, the fetal lie of this fetus is longitudinal lie. The fetal presentation of this fetus is cephalic presentation, because cephalic presentation if the fundus contains the buttocks. If the fundus contains the head, it is breech presentation. Okay? Okay. We shift then to the umbilical grip. Umbilical grip, you should concentrate with me because it needs more attention. We perform the umbilical grip to identify the position of the fetal back in relation to the anterior abdominal wall of the mother. For this purpose, we divide the anterior abdominal wall by three lines. The first is the midline, assigned with number 1. The second is the mid-clavicular line. The third is the mid-axillary line. And on the other side, the right mid-clavicular and the right mid-axillary line. We have here 6 areas for possible position of the fetal back. We have the area 1 here between the midline and the left mid-clavicular line, and this is termed left anterior area. And we have the second on the left side, which this is termed left lateral or left transverse area, and the third is the left posterior area, and the same condition on the right side. The same condition on the right side. So we have the possibilities that the fetal back may be in the left anterior area, or the left transverse or lateral, or the left posterior, or on the right side. This is a condition of the fetal positions on encephalic or vertex presentation when the head is flexed, or in the face when the head is extended. The back is the same, but the presentation is different. The back is the same and the presentation is different. We give an example to facilitate this condition. We have 4 positions, as we mentioned in the part 1 of obstetric case taking. In the first position, whatever the presentation, the fetal back is anterior and to the left. And the second position is the fetal back anterior and to the right. The third, the back is anterior and posterior and to the right. The final fourth, the last one, is the left posterior position. These positions will differ if related in related to the presentation. Let's say in vertex presentation, the dominator, which is occiput, is at the same side of the back. So the same positions are present in vertex. That's to say, the first position is left occipito anterior and left anterior. The second, right anterior. The third, left right posterior, and the fourth is left posterior. The opposite occurs with face or brow presentation because the dominator, which is the mentum or the forehead, occupied an opposite position to the back. So the first position in the face presentation is the back, left and anterior. So the mentum or the face, right and posterior, and so on. Okay. How to perform the umbilical grip? We can perform the umbilical grip by one of two techniques, either by alternating methods or by, let's say, alternating method. We palpate each compartment and followed by the ipsilateral compartment, following it, the left anterior followed by right anterior, left posterior, left transverse followed by the right transverse, and so on. Or we complete palpation on one side, and in one side the left anterior, left transverse, left posterior. Then we start right anterior, right transverse, right posterior. This is one note. Another notice: what is the rule of your contralateral hand? Your contralateral hand must be supporting the contralateral compartment. For example, if I start palpate the left anterior compartment, we palpate with my right hand, starting from the fundal level until the pelvic inlet, from above downward, searching for the fetal pack. My left hand is supporting in the right anterior compartment to avoid slipping of the fetus. This facilitates palpation. What I search for? I search for the fetal pack, which is smooth, convex, long fetal part, which is the back. Okay. We shift to the first pelvic grip. The first pelvic grip is performed to identify two things. The first, to confirm what fetal part occupy the lower uterine segment, and the second, to get an idea about the fetal head engagement. Okay. How to perform? While we are standing on the right side of the patient facing her, we fan our right hand, making the forefingers in one side and the thumb in the other, and apply my right hand to the lower abdomen of the mother, making my forehands parallel to her left inguinal ligament, and my thumb parallel to her right inguinal ligament and trying to catch the fetal parts in the lower trans segment, searching for the criteria: small, bulky, solid, soft, regular, irregular, palatable, not palatable, tender or not, and so on. And then, with these criteria obtained, we can confirm whether the lower trans segment is occupied by the fetal head or the fetal breech. We finally try to move the fetal part in the lower trans segment to detect its independence movement. Let's say palutment. Okay, okay. Finally, the last pelvic grip, which is the second pelvic grip. We should know that the second pelvic grip is only done in cephalic presentations. The aim of this grip is to determine whether this head is flexed, extended, or midway between extension and flexion. How to perform this? In the first, in the fundal grip, umbilical grip, first pelvic grip, we face the patient. In the second pelvic grip, we face the patient feet. Our back is in the patient face. Okay, okay. We start palpating from the patient's flanks, sweeping our ulnar, our palmar border of our of fingers toward the pelvic inlet. We are trying to palpate pony prominences. The pony prominence toward the back is the occipital bone. The pony prominence toward the patient face is the sinciput. When you palpate, stop and mark with a pen for this pony prominence and for that pony prominence, and evaluate which one is nearer to the pelvic inlet. If the pony prominence toward the fetal back, which is occiput, is nearer to the pelvic inlet, so the fetal head is completely flexed, so it is vertex presentation. If the contralateral pony prominence, which is a sinciput, which is toward the fetal abdomen against the direction of the fetal back, is nearer to the pelvic inlet, lower down, so this head is extended. If both at the same level, so this head is deflexed. So by this maneuver, we determine the attitude of the fetal head. Okay, okay. The combined grip is a quick method used by the experienced obstetrician to determine the location of the cephalic and podalic poles of the fetus in one procedure. While the patient is in dorsal position, the left hand of the obstetrician grasps the fundus uteri, while the right hand grasps the lower uterine segment The criteria for identifying the head and breech are the same as described before to identify the head and differentiate it from the breech. We come to the indications of vaginal examination in obstetric cases. We have 8 main indications for vaginal examination in obstetric case. It may be used in the best for diagnosis of early pregnancy when facilities such as ultrasound are absent, may be used for diagnosis of clinical types of abortion, in case diagnosis in cases of antepartum hemorrhage, where it is called double setup examination, which is risky procedure, and it should be done in the operative theater with all situations ready to perform the emergency cesarean section if bleeding occurs. Vaginal examination of obstetric case may be done in suspected cases of premature rupture of fetal membranes. Transvaginal diagnostic procedures such as transvaginal ultrasound examination, such as chorionic villus sampling, such as dry cascospeculum for diagnosing rupture of membrane, taking swabs for infection, and so on. Vaginal examination may be used for assessment of pelvic capacity at 38 weeks or more, for evaluation of possibility of vaginal delivery or not, easy vaginal delivery, and assessing pelvic disproportion, diagnosis of labor and follow-up of labor progress by evaluating the cervical consistency from soft or not, effacement and dilation, and the station of the fetal head, and also it may be used during labor for confirmation of the fetal presentation and fetal position. We start with these some of these indications. The bimanual start with bimanual examination for diagnosing early pregnancy, and this is not used in modern obstetrics. We diagnose the gestational age by evaluating bimanually the uterine size and softness, and this is a practice of the past. We may use vaginal examination to evaluate the cervical consistency, effacement, and dilation during the process of labor. We may use it to evaluate the station of the fetal head in relation to the ischial spine as shown in this picture. We may use it for evaluation of the diagonal conjugate for evaluation of the pelvic inlet capacity. If the sacral promontory is filled, it is short diagonal conjugate, and we in your right hand, this picture measure the diagonal conjugate, directing the index and the middle finger toward the sacral promontory, and measuring the distance from the tip of your finger to the subpubic part, and the other picture shows evaluation of the pelvic outlet by putting your fist on the perineum in between the two ischial tuberosities. The third and the next indication for evaluation of the cervix to define the type of of abortion, link abortion. If the cervical internal os is opened, it is inevitable abortion. If it is less, if it is closed and not containing the product of conception, it may be missed, or it may be complete abortion. It is also may be open in incomplete abortion. So we can evaluate the clinical type of abortion, whether it is threatened, inevitable, incomplete, complete, missed by examination of the cervix, cervical dilation and condition. This picture shows the inevitable abortion, and this is a missed abortion, and this incomplete abortion. This is a threatened abortion. We also can determine the fetal presentation position by palpating the anterior and posterior fontanelles of the anterior and posterior fontanelles of the female of the fetal head, and relate it to the sacral promontory posterior and pubic rami anterior, and can precisely define the fetal position as shown in these figures. These are variable positions, can be palpated. The anterior fontanelle is triangular and membranous, can be easily felt, and posterior fontanelle is usually smaller and osseous, not membranous, and we can identify the fetal position by differentiating vaginal palpation between the anterior and posterior fontanelles, and confirm that with the sagittal suture. Sagittal suture should be in the middle of the pelvis. If it is tilted to one side more than the other side, this condition is called asynclitism. So we can define the fetal position and fetal station by vaginal palpation during pregnancy. We come to the bedside urine analysis after completion of examination, as discussed. We should ask the patient to get some urine sample, midstream sample, and test with strips for glucose and proteinuria, albumin, to identify if there is proteinuria or glucosuria. Here we almost completed the obstetric case taking. I wish you understand the explanation, because this is very important for evaluation of your cases. We come to self-assessment to evaluate your understanding. In this figure, mention the name, the aim, and technique of each maneuvers: A maneuver, P maneuver, C maneuver, and D maneuver. A, what is this maneuver? It's a fundal grip. Its aim is to identify the fetal part occupying the lower transept. In B, is umbilical grip. Identify the fetal back position. C. First pelvic grip. Identify what? Which part occupying the lower trans segment and engagement. Good. D. The second pelvic grip to identify fetal head attitude. Okay, another self assessment. What is the fetal presentation and position in A, P? In A, the head is related to the pelvis, so it is cephalic. Where is the back? Good. The back is at the right side and posterior, and so this presentation is cephalic presentation, and the back is right posterior, so it is right posterior position. The P, figure P, is left posterior position, left posterior position. C, right anterior position. D, left anterior position. Good. Thank you very much. And I wish you all the best of luck.